So
Yeah, we'd like to start on time.
yeah, and then I think I'm going to share the screen with our screen share with the title,
Mhm.
and then we'll take off. So
Gaurang, do you want us to turn off videos when someone else is speaking for the presentations?
uh,
Yeah,
what do you mean?
I think so, Anna. Everyone can turn off their
Cameras.
Audio,
Camera.
video and audio.
audio, right?
At least audio, probably good to do video as well. All right. I guess we can go ahead and get started. And
Yep.
okay, so good evening and welcome everyone to our symposium on imaging, Alzheimer's disease, and dementia. I'm John Jordan, chair of the ACR Commission on Neuroradiology and moderator for this session. And my co-moderator is Gaurang Shah. He is a professor of radiology and associate chair at the University of Michigan. This session is sponsored by the ACR Commission on Neuroradiology and the Commission's Dementia Committee, and co-sponsored by the Michigan Radiologic Society and the California Radiologic Society, both of which are state chapters of the ACR. And all of our speakers and moderators today are also members of the ACR Commission on Neuroradiology. Today's session will be an exciting and informative program, and we thank all of you for your attendance. The session is entitled ARIA in Focus, Imaging Criteria, Reporting Recommendations, and Case-Based Insights. Your faculty for today's webinar are leading experts in the field, including Tammy Benziger from Washington University in St. Louis, Anna Franceschi from Northwell Health, and Greg Zuharchek from Stanford. We're so fortunate to have them. They are indeed an outstanding panel and august group of individuals. Before we get started, a few announcements are in order. 1 hour of CME credit will be available for this webinar. The webinar is being recorded and will be available online as an enduring activity for those that may have missed this session or would like to view the course again on the ACR Commission on Neuroradiology webpage. If you would like to direct a question to the faculty, you may do so by entering a question in the Q&A panel. You can also use the chat function to communicate with fellow attendees during the session. You can minimize the chat box if you do not want to see the chat messages, but please do not place your questions in the chat function, rather in the Q&A panel. Please note that you can find out more about additional educational opportunities for neuroradiology and other radiologic specialties through the website at acr.org under the Lifelong Learning and CME tab. There you can also find information about upcoming ACR courses, including how to register for them and gain additional educational and clinical training. So without further ado, it is my pleasure to invite my co-moderator, Gaurang Shah, to the virtual podium, who will start us from there. Gaurang?
Thanks a lot, John. It is my great pleasure to welcome you all to the very first neuroradiology webinar of 2026. My name is Gaurang Shah. I'm a professor and associate chair of radiology at the University of Michigan. I'm a member of the Neuroradiology Commission of ACR and consider myself as a uh, as a family member of ACR and MRS. I'm also a member and past president of Michigan Radiological Society. As John said, radiology education is one of the very important prime missions of Neuroradiology Commission. Now, the board of Michigan Radiology Society has very kindly decided to sponsor 3 events in the first half of 2026. The California Radiological Society has also very kindly joined our efforts, and they are the co-sponsor of the event. I thank the board of CRS and especially the president-elect, John Go, for their consideration. And it is my pleasure to introduce the president of Michigan Radiological Society, Dr. Andrew Woodrow. So Dr. Drew Woodrow is a musculoskeletal radiologist who is practicing in Grand Rapids, and he is very well trained at the University of Michigan as a resident as well as a fellow. And he would like to welcome all of us. Drew?
Go blue, Dr. Shah. Thank you. And thank you, Dr. Jordan, for the wonderful introduction. I just wanted to say welcome to all of you for coming, because without our audience, we wouldn't have a great webinar. So thank you all for coming. Thanks to our nationally renowned experts that we have here on the screen. We're so happy to have you for our first webinar, ARIA in Focus. And thank you to the Neuroradiology Commission of ACR, the MRS, Michigan Radiological Society, of course, and the California Radiological Society. Keep an eye on your email and Dr. Shah's Twitter page, or whatever other means you may get your information for an announcement to come for 2 more dates coming in early 2026. So with that, we will move on to the informational part of the webinar.
Thanks a lot, Dr. Woodrow, for your warm welcome. The current webinar is on ARIA, which is the amyloid-related imaging abnormalities. And it's encountered by all of us in day-to-day practice, and the volumes are going up with more and more drugs are cleared by FDA for the treatment of Alzheimer's disease. We have world experts right now as our faculty panel. And the very first speaker is Dr. Greg Zaharchuk. He is a professor of radiology at Stanford University. He's a very well-published scholar and also a past president of American Society of Functional Neuroradiology, the ASFNR. And he will introduce us to the arcane and fascinating world of ARIA. Dr. Zaharchuk?
Thank you. I will then share my screen. All right. Let's see. I should be able to go to that. There we go. All right. Can everyone see that? We get like one confirmation.
Yes.
Excellent. All right. So I get the honor to start off and just introduce us, and I'm very excited to hear the other talks build on this. Let's see. Here are my disclosures. So today we're going to be talking about dementia, and specifically we're going to be talking about Alzheimer's dementia and the kind of imaging follow-up that we need for that. And I just want to take a moment just to say that, of course, dementia is an umbrella term for a lot of different types of memory loss. But today we're going to be focusing exclusively on Alzheimer's disease, which is usually thought to be about 70% of all dementias. So Alzheimer's disease is obviously a major public health issue. I think the statistic that I find most amazing is that it is the #1 non-accidental cause of death without any treatment. And I put an asterisk next to that because we will be talking about the very first treatments for Alzheimer's disease today. Of course, it starts with memory and thinking impairment, but eventually patients can't carry out simple tasks for themselves. And it has a very significant toll on financial burden, about $1 trillion estimated by 2050. And this is, of course, an underestimation. So in this background of great need, I want to start talking about some of the therapies that have come along in the last couple of years. And the first drug, disease-modifying drug to be approved by the FDA was lecanemab in 2023. And the major findings of the study for which it was approved was that it was able to slow progression of AD by about 30% over 18 months. We still don't have much data on longer time points yet, and some neurologists still believe the drug is ineffective or minimally effective, and differences could be due to unblinding. However, we are seeing a lot of uptake of this drug, at least in our area. And the reason that we're going to be talking about this is because of safety issues that require close MRI monitoring. About a year later, a second drug was approved called donanemab with very similar findings, about 30% slowing of Alzheimer's disease. It has some differences from lecanemab in that while both of them are infusions, this is infused every 4 weeks as opposed to lecanemab, which is infused every 2 weeks, so more convenient for the patient. Interestingly enough, this trial required patients to also have tau pathology, which is another Alzheimer's biomarker. But to prescribe the drug, people do not need tau imaging. And the other interesting thing about the trial and the approval is that this can be monitored with amyloid PET. And when the amyloid PET shows that the amyloid has been cleared from the brain, the treatment can be stopped. So this is a real advantage for our patients. So the reason that we would like to stop it, of course, is the concerns about safety. And the safety concerns come under the heading of ARIA, which stands for Amyloid-Related Imaging Abnormalities. This was first noticed in the animal literature and comprises ARIA-E and ARIA-H. And I'm going to talk about each of those in a little bit more detail in the next couple slides. So ARIA-E is basically, the E is for edema, usually seen best on T2 flare. You can also see sulcal flare abnormalities or effusions. They can be in variable locations, they can be multiple. Now, this is usually asymptomatic, but symptoms can occur and symptoms are very diffuse. If you suspend the treatment, flare tends to resolve over a period of months. I want to get you guys really familiar with the idea of grading ARIA using a standard template, and this is one that was used in both of the trials. So ARIA-E is considered mild if the size of the abnormality is 5 centimeters or less and monofocal, moderate if it is less than 5 centimeters but multifocal, or between 5 and 10 centimeters, or severe if it's greater than 10 centimeters and mono or multifocal. So let's just show a few examples. You'll see a lot of other nice examples during this talk. This is a woman who came in treated with an amyloid agent and had a routine follow-up. She was asymptomatic, and this was her MRI. And you can see here there are areas of flare abnormality seen in the occipital lobe and the temporal lobe. And the first thing when we see that is to look back on the original images and make sure that those findings weren't there before, and indeed they were not in this case. So this, since there are more than one location, would be graded as moderate ARIA. Now, when you're differentiating ARIA-E, you have to think about other pathologies. Now, in a patient who's on these drugs, it really has to be a major concern, but there can be other mimics. One mimic is white matter changes. We all know that these patients are older. They can get white matter changes. And to differentiate them can be very challenging. But again, mostly you're looking for something that looks a little bit more like the next possible mimic, which is PRESS. Now, PRESS for all the world looks like ARIA-E, and I would be hard-pressed not to call ARIA-E in a patient receiving these drugs. But just remember that PRESS frequently develops in association with other situations, such as cytotoxic medications, preeclampsia, sepsis, and autoimmune disorders. Some of you may be familiar that you can get a CSF artifact from inhaled oxygen. So if a patient is on oxygen for some reason, that can also show sulcal hyperintensities that could be mistaken for ARIA-E. And then finally, the last thing to really worry about are CSF flow artifacts. So we know that using 3D FLAIR is quite good at suppressing these, so highly recommend including this in your protocols. Okay, next let's talk about ARIA-H. The H stands for hemorrhage, and usually this manifests itself as microhemorrhages, which are small punctate less than 1 centimeter lesions, or siderosis, low signal in a sulcus. Now these may be separate or they can overlap with ARIA-E. So ARIA-H, shown here on the right, also has a grading system, and it's a little bit simpler. It's graded based on count. So microhemorrhages, if you have less than 4, it's mild, moderate, 5 to 9, and severe, greater than 10. For superficial siderosis, 1 location is considered mild, 2 is considered moderate, and more than 2 is considered severe. So let's look at a case of ARIA-H. This is a patient who came in with a pre-existing microhemorrhages, shown here by the arrow. And after the 3rd dose, as we would expect, that would not go away. But if you look at another slice, you can see that there is an increase in the amount of microhemorrhages, maybe 2 new microhemorrhages there. And so this would be classified as mild ARIA-H. So how often do you expect to see ARIA? The trial suggests that you might see it about 10 to 20% of the time. And I think this is what we've seen certainly in our groups of patients. And just a little bit about the characteristics of ARIA. The risk factors, of course, are increased dose of anti-amyloid therapy. It is more common in people who have an ApoE4 allele, particularly homozygotes, as shown by the green bar. If you start with microhemorrhages at baseline or have severe white matter disease, you're also at higher risk. And in fact, typically, we don't offer therapy to those patients at Stanford. The time course is usually early. Usually the first 6 doses is where you will see it. So that's why we monitor usually mostly within the first year. And the severity, fortunately, it's frequently asymptomatic. And then the severity that we see is mild, much more common than moderate or severe, fortunately. Now, ARIA-E is almost always transient. If you suspend dosing, it will go away. ARIA-H almost always stabilizes, which means that if you have a new microhemorrhage or a new area of superficial siderosis, you should expect to see that on follow-up images. However, while that is somewhat comforting, there have been quite severe consequences, and this is an article just detailing a case study of a patient who had multiple cerebral hemorrhages who was treated with TPA. And since this, we've learned that mixing anticoagulation and anti-amyloid therapy is probably not tremendously safe. This was a patient who came in with a left MCA branch occlusion, was given IV TPA, which would be an appropriate treatment for that. And then 50 minutes later developed hypertension, and her non-contrast CT showed extensive multifocal ICH. So this is something certainly to be aware of, and I think the other speakers will be talking about how we deal with this in clinical practice. We have to realize this is really important because this population is elderly. There are multiple comorbidities. They're at high risk of stroke. And communication in hospitals is, as we know, often very challenging. So how do we deal with this? Maybe we need standard ED triage questions. Are you on anti-amyloid therapy? Medical bracelets might be happy. But I think we really have to take it on ourselves and really try to educate our techs, because I think the CT techs are going to be the first people to see this typically. All right. So what is the schedule for AD treatments? Typically, you would want to get a baseline MRI to see if you're eligible. The trials have allowed MRIs up to 1 year prior, but perhaps we should try to make those a little shorter duration, because if you have a microhemorrhage in the interval, you might mistakenly call that ARIA-H when it might just be something that was existing before giving the treatment. For patients that are asymptomatic, we monitor them quite extensively. I have this highlighted in yellow because this is a new recommendation to add an extra monitoring MRI. Some sites might want more. We certainly are doing a bit more than that. Now, remember, if patients are symptomatic, of course, you would do this at any time. And then once you have documented ARIA, typically every month, you would get a separate MRI until it resolves or stabilizes. So I think there's some data out there that you'll see that this tends to lead to about 8 to 10 new MRIs per year for the first year of treatment. So what are some considerations for baseline and follow-up imaging? For baseline, try to use a scanner that you can keep consistent in the future, particularly regarding field strength. If both 1.5T and 3T are available, considering using 3T, since then there's going to be less risk of overcalling microhemorrhages, which are going to be more visible on 3T. 2D versus 3D should be standardized. You might want to consider using both. Reporting the field strength and the type of susceptibility sequence used is important. Just remember the trials used gradient echo imaging. And then report the number of microhemorrhages and the number of severity of white matter hyperintensities, because this is something that can be an exclusion criteria for treatment. Now for follow-up, again, you want to use the same scanner if possible. If not, use the same field strength. Keep 2D versus 3D imaging consistent, and again, consider using both. Avoid switching back and forth because that can be very challenging. Microhemorrhages are going to have different conspicuity on different types of sequences. Any new abnormalities should be clearly documented and communicated with treating physicians, and really want to emphasize using the classification of mild, moderate, and severe. And why is that? It's because these are really linked with treatment decisions. So here is kind of a nice chart from Patrice Cogswell from an AJR article, just demonstrating the ARIA severity versus the clinical symptoms and just kind of what the treatment is. So the C being continue dosing, the S being suspend dosing until it gets better, and the D being discontinue treatment. Now I want to finish with the ASNR recommended protocols. You can go to the ASNR site and find these for your particular scanner. They recommend 1.5T or 3T imaging, 2D or 3D flare. Again, I would recommend both. And then definitely 2D T2 star gradient echo imaging with the appropriate TE. I can't tell you how many cases I've seen where people have inappropriately short TEs for gradient echo imaging. They also recommend DWI. In some sites, you might want to consider T1 high resolution imaging or susceptibility weighted imaging. And just remember, no contrast is required for evaluating ARIA. So, as a take-home message, AD patients are now being treated with these disease-modifying therapies. They need proof of amyloid positivity, and they need a baseline MRI without severe white matter disease or microhemorrhages. ARIA is a side effect that must be monitored carefully with MRI several times during the first year. It is usually asymptomatic or mild, but catastrophic events have been observed. Be aware of the potential mimics out there, and please consider using standardized imaging and reporting guidelines. Thank you very much for your attention. And with that, I will stop sharing.
All right. Thank you so much, Greg, for that superb overview. I think we're going to hold questions for the Q&A portion of this session, just in the interest of time. I also would just like to remind everyone, if you have questions, you can in fact put those into the chat function. I think that for some of us, the Q&A panel is not readily accessible, and perhaps for some of you. So we can easily put those into the chat function and still accomplish the discussion. Okay, so my privilege is to introduce our next speaker, who is Dr. Tammy Benzinger. She's a professor of radiology and neurologic surgery and medical director of MRI services at Washington University School of Medicine in St. Louis. Tammy's talk is entitled Amyloid-Related Imaging Abnormalities, Cases in Clinical Trials versus the Real World. Tammy, welcome to the virtual podium.
All right, thank you so much. It's really an honor and a privilege to be here with all of you tonight, and I'm seeing many familiar names from Michigan and California, as well as some people from Missouri have jumped in, and I'm even seeing some of our collaborators from South America have joined. So really excited to be here and present this to all of you. All right, just got to figure out the right button. There we go. These are my disclosures. I do have research support from a number of institutions and participate in clinical trials and consulting related to Alzheimer's disease. We've been through this grading scale again. We're going to be repeating a little bit of information. And really, I want to say all of the cases that I'm going to be talking.
Tammy, you're muted. You're muted.
That was bizarre. Okay, can you hear me now?
Yes, you're
all
good.
Right. So I was just saying, like, these topics seem pretty easy when you see it in the textbook or on a paper, but when you're sitting in the reading room, it can be a bit of a challenge. So some of the things we'll be repeating just because they are important to be thinking about. All right. So part of this is that there's standardized grading. Part of it is that there are going to be multiple MRIs, and some of these are going to be at standardized time points based on the drug that the patient's receiving, but others are going to be popping up based on a prior abnormal MRI or also because of symptoms that they might be reporting. So let's jump into some cases. So this was actually from one of our clinical trials, but it gives us a really great example of how we can look at something over time. So this is a patient we're talking about for baseline imaging. You guys have heard the background on what we're looking for on these scans. And so based on these images, would you consider this patient a good candidate for anti-amyloid immunotherapy? Well, obviously imaging is critical. B, this is a really important concept. So I have heard colleagues say, oh, this looks like a normal brain MRI. He can't have Alzheimer's disease. Well, that's not true anymore. In fact, to be a good candidate for therapy, we're looking for people that have the very earliest disease, the mild impairment, which means their brain MRI might look normal. In this case, we don't see signs of infarcts or extensive white matter disease. So it's not vascular dementia, and you can't really see it on these images, but there was one baseline microhemorrhage. So in general, we usually say 5 is the cutoff on microhemorrhage at baseline. So yes, this would be a good candidate for therapy. Here's our first monitoring MRI, and so you're going to see a lot of these. And I think what you have to just remember is about 20% of them will be positive. So this is not a rare finding to look for. This is a common finding to look for. But in this case, the first MRI is actually negative. Then they come in again. So these are just scheduled on a schedule coming in. So here's our next monitoring MRI. So again, now, does this patient have ARIA? And of course, you've all been prepped for it. You know that you're here for an ARIA webinar. So yes, this is ARIA. I'm going to just point out, because I've seen now multiple examples of this, some people think that ARIA is only vasogenic edema, but remember it's also the sulcal effusions. In this case, there's a scap of normal tissue in between. So we have occipital and temporal lobe. So it would be 2 regions, moderate ARIA E. And yes, just the effusion, even if it doesn't have a edema that you see with it, that is still ARIA. Next question is, do they have ARIA H? So it's been pointed out, it's very common for you to get microhemorrhages and siderosis, ARIA-H, in the same places that you see edema. So what I do is, if I'm looking at a scan, I'm looking for all the findings at first, but then when you go back to do that second look, use the edema to tell you where to look for the hemorrhages. So you've had a chance to think about this one. Hopefully at this point, you all saw the 2 microhemorrhages. And so remembering that rule of 5s, you needed 5 microhemorrhages to bump to moderate and 10 to bump to severe. So this would be mild ARIA-E. Now, this is just showing you what happens over time. This is what we expect, is that the ARIA-E will start to resolve, and it doesn't have to resolve at the same time. So the temporal lobe resolved first and the occipital lobe resolved later. But then what else do you see? As that temporal lobe resolves, even though it's looking better on edema, it's actually looking worse for the hemorrhages. And in fact, you want to keep getting follow-up MRIs until both the edema resolves and you want the ARIA-H to stabilize. So if you're still seeing new findings on the next scan, please be sure to recommend that they get follow-up in 1 or 2 months. Whether or not they've suspended the dosing. So it's a very common mistake I've seen, is that people, they stop the medication, they stop getting scans, but it doesn't mean that you're out of the woods. You really need to keep monitoring until the patient has completely recovered radiographically. So what's our experience? We're around 550 patients on therapy now. Our first 180 patients generated 1,000 extra brain MRI visits, because you have a lot of people getting the baseline screening, you have the standardized monitoring, you have all the extra monitoring visits. So you really have to think about, how are you going to incorporate this into your workflow? Like Michigan, we have a very spread out state. Most of it is rural, and surprisingly, only a minority of our patients want to come all the way to the downtown St. Louis area to get their scans. And so they're dispersed geographically across Missouri and Southern Illinois. And this is just an example of a couple that in our therapy clinic that was just written up. So they live 2 hours away from Sullivan, Missouri, which is 2 hours away from St. Louis. So if I said they had to get all of their scans at our site at 3 Tesla, I wouldn't be able to treat these patients. And so you really have to plan across your network for standardizing the imaging and also standardizing the training. And this is the kind of the real world experience, is to be proactive as this is happening and making sure you have these things in place. Now, these are just kind of a list of the things I have seen. All of these things have happened to me. And these are the problems that have resulted. So we've missed some of the follow-up MRIs. It causes a lot of anxiety for families. I've seen very, very commonly, someone will see a focal effusion and say, oh, automatically lack of flare suppression, they must need a CT angiogram. No, you don't need to get a head CT or a CTA. If they're on therapy and you see ARIA, you call it ARIA and you need to call the neurologist so that they can manage it. I've seen people receiving doses when they should have been held because the radiologist didn't use the grading scale. So I've also seen radiologists, I've seen doses get held that should have been given because something looks bad and we'll call it severe without understanding that severe is an exact scale. So really glad you guys are attending the webinar, thinking about this. It's been pointed out there are a lot of resources out there through the ACR and other organizations that can really help you do this correctly. So let's just go through just a little bit more on our cases. So to point this out again, the clinical trials were at 3 Tesla and they used the GRE T2 star. Now, a lot of us think, oh, SWI is always better. Well, I'll just point out some of these can be pretty confusing. So this is the same patient. There's no difference in the findings, but depending upon how you run the protocol, you can make the findings come and go, whether it's the siderosis or the microhemorrhage. And in fact, this protocol on the far right, there's a microhemorrhage, almost looks like a vein sitting there. I would argue, honestly, of these scans, the one that I can see it most clearly on is this 1.5T GRE. But, so for our institution, we're allowing both field strengths just because our network, we don't have 3 Tesla scanners out in rural Missouri. But we are actually performing both the SWI and the GRE at every visit. And we're doing our baseline scans at 3 Tesla. And we're also asking when they do their annual follow-up that they come back when they're seeing the neurologist, that we get a new baseline 3T scan as well. Okay, so here's just one more case quickly. Case 2, so they're coming in for an eligibility exam, 74-year-old, gradual memory loss. And these are the kinds of things the neurologists really care about. They're doing home repairs, installing thermostats, driving independently. That tells you that they have just really early stage disease. They also look at things like a mini mental clinical dementia rating. This person was not on anticoagulants, but is on aspirin. Most centers are allowing patients on aspirin to get therapy. Some people are allowing patients on things like Eliquis, but that's definitely a red flag and a concern. Not that it increases your risk of ARIA, but if you do have a hemorrhage, it increases the risk that you're going to have a significant bleed with that hemorrhage. The ApoE status is also that predictor of risk. We're going to be hearing a lot from Dr. Franceschi about PET, but I'll just show you. He had a forbetaben amyloid PET, and it's a nice classic positive scan where we have uptake in both white matter and cortex. And you can see the control region is going to be the cerebellar gray matter is negative. Baseline MRI, hippocampal volumes are normal. And I'm showing you just to emphasize again, normal hippocampal volumes are actually what we hope for. We're trying to treat these patients before they have that brain atrophy that we think about for Alzheimer's disease. And then these are those key images we're going to look for ARIA. So we have the flare, the SWI, and the GRE. So based on these images and that history, do you think this would be a good candidate for therapy? And the answer for this one was yes. And this is somebody we went ahead and treated. Now we're going to get into some monitoring scans. I'm purposely making these images kind of tiny for you to as best as I can mimic that experience in the reading room where you have a lot of images, you're trying to look at them quickly, give you a second to look at it, and then I'm going to blow it up for you. So hopefully now you've seen enough cases, you're ready to notice that we do have vasogenic edema and sulcal effusions in the right parietal lobe, and that is accompanied by two separate sulci with siderosis. We did not see a connection, so this would be two areas of superficial siderosis. So for your grading scale, what would you grade this on? So one area of flare hyperintensity makes it mild. Two areas of siderosis puts us into moderate. So what happens next? Well, so this is really important. The radiologist needs to grade the exam based on the images. The neurologist has to then do a grading of the clinical symptoms based on symptoms, and the two come together to determine what happens next. So many times I'm seeing the radiologist skip the grading because they think, oh, that's based on symptoms. They're actually separate grading. So please do apply the grading and use the standard scale. And you can see there are different algorithms for what happens for whether it's the edema or the hemorrhages. Okay, continuing on with case 2. I don't know if you guys are taking a look, but you can see now that over time, that ARIA E, the edema, as we saw before, it should resolve, versus the siderosis is going to stay there, and you'll keep seeing it again and again. And I'm trying to show you as much as I can, both the SWI and the GRE T2 star, so you can take a look at that. That if you've been staring at this image, you may have seen another finding. So what's happening here? We've got this flare hyperintensity with central lack of suppression in the left centrum semio-valley. Well, turns out he had an unscheduled MRI in between these visits where he came into the ED complaining of dysarthria and right arm numbness. So the key sequences that we include for these exams are flare, SWI, or GRE, and diffusion. And that's because diffusion, the symptoms of a stroke or the symptoms of ARIA are so highly overlapped. And as we've already heard, the consequences of getting the diagnosis wrong can be really dire. So this is an example of someone that's coming in, and you can see this early subacute infarct has diffusion restriction and some flare hyperintensity, which over time resolved. Finally, I just wanted to point out that as we saw before in the first case that earlier this evening, places where you have abnormalities can predict later ARIA. So this is why we care so much about being careful about microhemorrhages and siderosis on the baseline scan. So this patient actually had superficial siderosis in the right occipital lobe before the treatment, but we didn't mention it. And that's exactly where he later developed the siderosis during the course of ARIA. So really important to go back anytime you see a new finding, to go back and try to look and see, was there something there before and what can we learn for it? And again, this is where he has the ARIA E. And then finally, just remembering that ARIA E will resolve on flare, but of course, infarcts will not. Alzheimer's and vascular dementia very commonly coexist. And it's important to be thinking about both of these things in that patient population now that we're here in the real world. These are some links, and I understand the materials will be online, et cetera, later. But if you're interested, there are a number of really nice references that are available now, including the ACR has just published some new appropriateness criteria for dementia imaging, resources from other organizations as well, which you may find helpful. And so with that, thank you for your attention, and thank all of our study participants over the years who've really brought this together for us so that we now have therapies.
Garang?
Yes, hi. So it is my honor and privilege to introduce the third speaker, Anna Franceschi. She is an associate professor of radiology, director of dementia imaging, and director of molecular neuroimaging at Donald and Barbara Zicker School of Medicine at the Hofstra Northwell at Lenox Hill Hospital in New York, New York. She is a world-renowned expert on ARIA, and she's going to tell us what is the amyloid quantification in the clinical setting and how it impacts the treatment of ARIA. Anna?
Thank you so much, Garang, for the warm introduction. I'm really excited to be here. And after these two wonderful talks on ARIA, including Tammy's case presentation, I will pivot a little bit and focus on amyloid PET and specifically amyloid PET quantification in the clinical setting, since we are seeing more and more of it in clinical practice as we look to assess treatment response and target engagement in patients on these anti-amyloid therapies. So there we go. These are my disclosures and my grant funding information. And so to start, in the United States, there are 3 FDA-approved amyloid radiotracers for clinical use. At my institution, we routinely use 2 out of these 3, but they're quite comparable, and they all have greater than 90% sensitivity and specificity for detection of increased cortical amyloid burden. Now, historically, our approach to interpretation of these cases was quite binary. Images or scans were called negative if there was only nonspecific binding to the cerebral white matter, and then positive, as you see in the examples in the bottom rows, if there was extension of the radiotracer to involve not just the white matter, but also the cerebral cortex. Now, this brings me to the large-scale IDEA study, or the Imaging Dementia Evidence for Amyloid Scanning study, which assess the clinical usefulness and impact on patient-oriented outcomes of amyloid PET in patients with MCI or dementia of uncertain etiology, and it enrolled over 16,000 Medicare beneficiaries across the United States. Now, the study had 2 specific aims, and I'd just like to briefly focus on the first aim, which took a look at the impact of amyloid PET on patient management at 3 months after the scan. And what they looked at was changes in medical management, which were reported in nearly 2/3 of cases, and then change in diagnosis, meaning that the patient's diagnosis went from Alzheimer's disease to a non-Alzheimer's disease dementia or vice versa in 1/3 cases. And this, especially the second point, really far surpassed the pre-specified outcomes, and there was a lot of excitement in the field that amyloid PET might be reimbursed for clinical use. However, we had to wait a little bit until these new anti-amyloid therapies started receiving FDA approval. The first drug, which was quite controversial, was aducanumab, which targets the beta amyloid oligomers and fibrils, but it's been pulled off the shelves in the United States for well over a year now. Then came lecanemab or Leqembi, which primarily targets the protofibrils, and then finally donanemab or Kinsula, which targets the beta amyloid plaques. And really what happened was that very, very soon after the traditional FDA approval of lecanemab in July 2023, the CMS did announce that they would provide broad coverage of these FDA-approved disease-modifying therapies for eligible Medicare patients. And then a few months thereafter, they expanded access to amyloid PET by finally lifting a long-standing, very restrictive national coverage determination for amyloid PET and ending coverage with evidence development. And now the reason that these changes took place have a lot to do with the phase 3 clinical trials for the FDA-approved agents. Greg briefly summarized the clinical efficacy of the efficacy of these agents and their effects on cognition, but amyloid PET was also used as one of the endpoints in both trials. And you can see, if you look on the graph on the left, that in contrast to patients on placebo, most of the patients on Leqembi went on to clear amyloid burden on their PET scans by the 18 months. Similarly, in donanemab, patients were tracked by amyloid PET with very similar results. And in addition, patients in the Kinsula trial were actually stratified by their tau level into a low to medium tau group and a high to tau group, at which point there was some both excitement and concern that tau PET might be a prerequisite prior to treatment with Kinsula, but that has not yet come to fruition. And so in the clinical setting, in my institutions and in many across the country, very shortly after CMS updated coverage guidelines for amyloid PET, we went from scanning only a handful of amyloid PETs each year, mostly self-pay patients, to routinely scanning about 50 to 70 cases per month. And now more recently, we're not only obtaining amyloid PET at baseline, but are also obtaining amyloid PET at 12 or 18-month marks post-dosing to assess target engagement and treatment response. And now this brings me to the appropriate use criteria for amyloid PET in the clinical setting that were published last year by the Society of Nuclear Medicine and Molecular Imaging and the Alzheimer's Association. So some common features of appropriate amyloid PET use include in symptomatic patients, in order to support the diagnosis of Alzheimer's disease, and also to plan and monitor amyloid targeting therapy. Now, after these appropriate use criteria came out, and also with expanded use in the clinical setting, the FDA finally also updated the labels for the 3 approved F18 labeled amyloid PET tracers. And what these updates included were expanded clinical indication for use in both diagnostic assessment and identification of appropriate candidates for amyloid targeting therapies. In addition, utilization of quantitative plaque metrics in conjunction with visual image interpretation and broader use for monitoring of therapy and also following progression of asymptomatic patients to Alzheimer's disease. And now that brings me to quantitative measures, which were initially developed and used in the research setting, but have now entered clinical practice. And I'd just like to briefly discuss with you the Centiloid scale. Now, the Centiloid scale was initially developed as there was a need for intertracer standardization of the SUVR metric in multi-center collaborations. It is an unbounded scale with 2 anchor points, so a Centiloid score of 0, which indicates the mean gray matter signal of young healthy controls, and a score of 100, which indicates typical Alzheimer's disease patient signal in patients with mild to moderate plaque. And really, the key principles of this Centiloid scale are its ability to allow us to robustly quantify longitudinal change. It also helps us to outline early-ish thresholds for amyloid positivity and define the range of positivity in Alzheimer's disease. And of course, simplify and expedite direct comparisons of amyloid PET results across sites and studies, thereby facilitating intertracer comparisons. So here is just a description of the pipeline that was used in the initial paper. So as you can see, the 100 Centiloid metric was marked by the mean signal in a group of 45 patients with mild to moderate AD dementia. And as you can see on the graph on the right, patients can have Centiloid scores above 100. And similarly, the Centiloid score of 0 was defined by the mean signal in a group of 34 definitively negative amyloid beta negative controls in their 20s. And so results can also go below 0. So again, although the score is anchored at 0 and 100, it is not limited to this range. Now, initially, the Centiloid score was conceived for the research setting, but has now translated into clinical practice. And as you can see, there is a number of FDA-cleared softwares for clinical use. Personally, I've been using MIM-Neuro for the last 2.5 years. Now, interestingly enough, recently there was a paper published that evaluated 2 different manufacturers, the Siemens Singo and the MIM-Neuro, for correlation of Centiloid measurements in the same patients. And reassuringly, the Centiloid scores from both of these softwares were highly linearly associated with research pipelines, but the authors did note that the Centiloid scores within patients could differ by greater than 10 Centiloid units. So if patients are close to the cutoff, caution should be used. And with that, I'd like to move on to 2 of my favorite images from great review articles. This one is from Pemberton's article, which was published back in 2022 in the European Journal of Nuclear Medicine and Molecular Imaging. And it highlights some key cutoffs that we should keep in mind in clinical practice, including a Centiloid score less than 10, which essentially means that neuritic plaques are absent and effectively rules out Alzheimer's disease. A score greater than 20, which indicates at least moderate plaque density, and a score greater than or equal to 50, which has the strongest correlation with AD diagnosis. These cutoff values and criteria were updated slightly in College's article in 2024, where they term Centiloid scores between 10 and 30 as evolving or intermediate amyloid burden, and then a score greater than 30 as established beta amyloid pathology. And the clinical trials that Greg discussed typically enrolled patients at Centiloid scores above 30, with mean Centiloid scores, depending on the trial, ranging between 75 and 95 Centiloid units. Now, when these scores are used in the clinical setting, they should certainly be used as an adjunct to visual interpretation and not just blindly following the quantification, since issues such as, for example, cortical lesions, for example, large vascular territory strokes, can potentially lead to underestimation of amyloid burden, or cerebellar lesions, which can potentially lead to overestimation of amyloid burden. And I've seen this even in cases where relatively small cerebellar lacunar infarcts. Now, the other potential issue is uptake outside of the in the cerebellum itself, which is typically seen in patients with autosomal dominant Alzheimer's disease, and this can lead to underestimation of the supratentorial amyloid burden. Now, with that, thinking about future directions and amyloid PET obtained for assessing treatment response, there was a paper published recently that introduced the TRACK framework, the so-called treatment-related amyloid clearance framework, which essentially helps us to identify patients with biomarker evidence for clearance of amyloid deposits who are on these anti-amyloid therapies, and is currently defined using amyloid PET only. Patients can be classified as either having partial treatment-related amyloid clearance or full treatment-related amyloid clearance, meaning that the amyloid PET burden drops between predetermined positivity thresholds, typically less than 24 Centiloid units. And the authors looked at the data from the clinical trials for all of the 3 FDA-approved agents, and essentially by 18 months, depending on the therapeutic, anywhere between 50 to over 80% of patients were achieving full treatment-related amyloid clearance. And when you look at the donanemab label in particular, it states specifically consider stopping dosing with Kisunla based on reduction of amyloid plaques to minimal levels on amyloid PET imaging. So with that, before I wrap up, I'd just like to briefly show you a couple of clinical case examples. So the first one is a 66-year-old female that had no clearance on her follow-up scan. So this was the baseline. The patient's Centiloid value was 104, almost 105. And when they came back for the follow-up 12 months later, they were still at a Centiloid value of 105. Here's a second example. This is a 79-year-old male who achieved partial clearance. So at baseline, came in with a Centiloid value of 113, and when he came back 15 months later, the Centiloid score had dropped to 60, 59.97. So this was a significant decrease from the baseline, but again, not below the cutoffs of either 30 or 24, which would be used to identify a negative scan post-treatment. And then finally, I have an 85-year-old female who achieved full clearance. So this patient came in at baseline and had a Centiloid value of 106. And then when she came back for her follow-up at 18 months post-starting therapy, the Centiloid value had dropped to a negative 2.5. So with that, I'd just like you to take home that visual reads with quantification effectively promote accurate determination of amyloid status, which is critical for treatment decisions. And quantification, especially with Centiloid units, should be used as a metric for target engagement, hopefully then leading to personalized dosing strategies of these agents based on PET biomarkers. So with that, I'd like to thank you for your attention, and I think we'll be moving to the discussion and question portion of the webinar.
Yes, thank you so much, Anna. That was excellent. And as you indicated, we are in the question and answer portion of our presentation here and symposium. I wanted to again invite people who would like to ask questions to enter them in the chat. Do we have any questions? And Garang, I'm not sure if you can see the Q&A
Yeah,
panel, but
I don't see any questions. So
I don't see it either. So do
if
we
they
have
want to ask, they can raise hands, I guess.
yeah, is the audience able to just talk or
I think so. They can
yeah.
talk probably. Yeah.
Do we have any questions from the
I
audience?
have a question for Anna if we wanted to get started.
Yes, please do.
So Anna, a fantastic presentation. I love seeing those post-treatment cases. In your experience, is it common now for people to be getting amyloid PET before and after therapy? And kind of what percentage of patients are you seeing that don't get an amyloid PET, do you think?
So, speaking with I don't see the ones that don't get an amyloid PET, but my understanding, at least speaking with my internal neurology group, is that everyone that they end up sending for treatment will have an amyloid PET at baseline in order to be used as follow-up. I do have a couple of neurologists in the academic circle who do not think that they will change their management depending on the follow-up scan. So they are choosing not to get amyloid PET at the 12 or the 18-month mark. But we are seeing every week, we are seeing more and more of these follow-up cases, and they can be quite interesting. I actually earlier this week I had a patient who at baseline, was amyloid positive. Actually, also had an FDG PET. The FDG PET and the clinical history were kind of consistent with posterior cortical atrophy, the visual variant of Alzheimer's disease. And when they came back for the follow-up, the send fluid had dropped to 16, so well below cutoff range, but looking at the images themselves, they still had really prominent right occipital lobe amyloid cortical deposition. So that was a really good case highlighting how the quantification cannot be a complete substitute for visual image interpretation. So I've started to see more and more interesting cases in that vein.
Great. We have two questions I see from the audience. One is from Stephen Wang, and he's asking on follow-up MRI scans, do you use the routine brain protocols or tack on the specific sequences, or do you just use those sequences?
So I can answer that one. So I'll refer you to their two different white papers from the ASNR that you can look for. Basically, essentially, it's going to be much better, in my opinion, if you generate a specific orderable and a specific protocol, because these sequences that you need for this, you can easily get them done in 10 minutes. Versus if you're adding them on to an existing brain exam, you run the risk it's taking too long, they're moving, and then you actually don't know the right history. And if you don't know they're here for monitoring therapy, it's really easy to go down the wrong pathway of calling it press or missing a subtle finding. So highly recommend when you're starting out to build order sets, build protocols on scanners, and just focus on those specific things that you need, because you really don't need the rest of the images, and that's going to make it easier for the radiologist as well.
I think Dr. Bapraj is here. He has raised his hand. Would you like to ask any question?
Yeah, thank you. Thank you for giving me this opportunity. It's an interesting topic. My questions are related to two major aspects, which are kind of not really into the picture. It's not very glamorous to ask these questions. But the thing is, the basis of the treatment is very early dementia. And that is one of the major limitations of starting these treatment modalities when they started. So my question to you is that what happens in the long-term follow-up of these patients? Okay, the patients had these changes in the short term when they were under treatment, but what is the long-term effect of these MRI findings? So if you say that the longest follow-up studies for lecanemab is only 18 months, and the longer the term is for the other medication is for nearly 3 years, 36 months. That's not a very good time period. So we don't know if these patients, if they are continued to have treatment, will they develop ARIA in the long term? That's one question. The other question to all three of the speakers is that one of the issues for giving these treatment is that there is going to be decrease in the cerebral volume, and consequently, there's going to be increase in the ventricular volumes. That has been documented. And that's the reason why, like most of the clinicians, they don't ask us to do neuroquant whenever they are looking for ARIA. So my question to you is, the FGD clearance, which is there, has it been validated to the cerebral volumes and the ventricular volumes? Because, more and more of the white matter is going to be lost. And per gram of the brain, the clearance of the amyloid may be fallacious, because there's a recent paper which came in 2025, late 2025, where they did a secondary analysis of the trial-based trial, I think. And then they said that, if you look at the individual clearance of patients, it's very modest. But if you just gather the entire data set of all the patients who underwent this form of therapy, it showed some degree of significance, which was shown in the right-hand side graph, which the last speaker said. So those are my three issues with ARIA imaging.
Dr. Bafra, those are very profound questions. So I think Dr. Zaharchak has given an answer on the in the chat box, and Dr. Benzinger has given a actually link to an AJNR article. But if anyone can answer this in brief, I think I will welcome one of the faculties to volunteer for that.
I would just say, I agree with your concerns. And, a lot of these studies have been done by big pharmaceutical companies, and they use imaging CROs, and we run into concerns that people aren't looking at the actual scans. So when we're reading these scans in radiology, the PET scans, what Anna's telling you about is she's doing a visual read and the quantification. And that's how the FDA label works. But when you look at what gets done in trials, a lot of it is quantification without necessarily correlation back to the imaging. I will say that the trials I've been involved in that have an academic collaboration and partnership, that's not the case. And the scans do get very careful visual inspections. In fact, Bob Kepi at the University of Michigan is a huge collaborator in a number of these studies, does very careful visual QC of those PET scans for many, many of these studies. And for our trials that I've looked at, and we've presented this and published it, we used partial volume correction with the PET scans. And the patients that have clearance have real amyloid PET clearance. And that's the same thing that Anna can talk to about what she's seeing in these clinical patients as well. So I think, the amyloid clearance is real despite these volume changes, but the volume changes are also real. So then I think there are open questions that we have about long-term, why do we see volume changes? People have hypotheses that the plaques themselves are inflammatory, that they have edema associated with them that goes away, but we really don't know, and we're missing a lot of, as you said, long-term outcome data, as well as autopsy data that's just starting to come together as some of the patients that have been in trials long-term are aging out of them.
Okay, well, thank you very much for that, Tammy. And I would just point everyone to the chat boxes if you'd like to copy some of the answers that have been put in there. That this is an opportunity to do that. I want to thank our esteemed speakers for their outstanding presentations, and the chapters and staff for supporting this program. I'd like to remind everyone that this will be recorded, and additional information can be obtained that way or review as needed. Again, we want to thank all of you for attending, and to everyone, we bid you a good night and farewell. Thank you.
Thank you.
Thanks so
Bye.
much. Bye.
Take care.
Bye, everyone.